This one tends to linger quite a bit longer.
A little more peppery. I'm gonna go for the milk this time.
Whoa.
Yeah, it's an upgrade.
That's present.
Yes, that is present.
Yes.
I guess transparency, integrity, and accuracy were areas of opportunity just a year or two ago.
But this one you could put. Probably couldn't put on a cheesesteak. Probably not so much.
Not in Philly, you couldn't.
No.
Welcome to a special edition of the System Logic Podcast. In honor of being on location in Nashville, Tennessee, we engaged healthcare leaders attending the AAPCP conference in some truly spicy conversations. This is the Hot Comp Challenge. Our guests will attempt to answer tough questions while trying some of the hottest sauces in town as we turn up the heat on physician compensation logic, administrative bottlenecks, and healthcare technology. No sugarcoating, no scripts, just raw data, fast pacing, and pure logic. Let's dive in.
Hi, welcome everybody to the System Logic Podcast. I'm your host, Jason Lee, and I'm joined today by Dan Iliff and our guest, Mike Gizzi from Suburban Health Organization. Mike, thanks so much for joining us.
Happy to be here. Thanks for having me.
So, Mike, we're here in Nashville, Tennessee, AAPCP conference. Tell us a little bit about yourself and how many times have you been to the conference?
This is my second time.
Okay.
Last year was my first adventure and really enjoyed it. It's a great conference. Different hotel this year, so that's a fun experience.
Great facility.
Yeah, last year's conference was outstanding.
Okay.
So the sessions, the networking, the content, all great stuff.
Yeah.
Really enjoyed it. So I think I'm in every year going forward.
I love it. I love it. And tell us a little bit about the organization that you're with today.
So I'm the Chief Transformation Officer at Suburban Health Organization.
Yeah.
It's a group of 31 hospitals between Indiana and Ohio.
Uh-huh.
And they're all independent.
Okay.
And I started my relationship with SHO, Suburban Health Organization, 7 or 8 years ago as a consultant.
Uh-huh.
And was providing advisory services to these hospitals. Mm-hmm. And things were going really well, and had an opportunity to transition to the other side of the table, join their leadership team.
Of course.
And it's been 3 years coming up in a few weeks, and no turning back, I don't think.
That's awesome. That's awesome. I think an organization like yours really supporting some of those independent facilities and some of those smaller facilities is something that really resonates with a lot of communities across the country, and I appreciate the work that you're doing out there in Indiana.
Yeah. One point I was going to make too is a lot of folks that are in the audience today typically work with one facility, right? So, or one health system that covers multiple hospitals underneath that health system. So you've got a unique perspective working with so many independent facilities and kind of seeing the inner workings of each one of those. So it's going to be really interesting to get your take today. I think a lot of people will enjoy your thoughts.
Yeah.
I definitely have lots of interesting takes, that's for sure.
Yeah, no doubt.
I like it. Well, as I mentioned, we are here in Nashville, Tennessee, home of the Nashville Hot Chicken. And so in honor of that, we are offering our Hot Comp Challenge today. What you have in front of you is some spicy chicken, and we've got a couple of extra sauces that we're gonna be diving into and trying, and we'll be asking you a few spicy questions as well along the way. Sound good?
I'm ready.
I like it. Well, why don't you dive into the first piece, the first sauce here. Tell us what you think. What are you tasting?
It's really good.
Yeah.
It's very good. It's very smoky.
It is definitely smoky.
Get any sweetness in there?
A little bit of sweetness. I was expecting a little more kick.
A little more punch?
So the kick came for me pretty late. So it just happened.
Yeah.
And but if you go to Hattie's Barbecue here in town, would you select that barbecue sauce as your choice?
I think I might not.
No?
Yeah.
I would go somewhere else.
Okay.
All
right. Not location, but I I would go a different flavor. Something
Different flavor.
Okay.
Yeah.
a little more bite.
You're more smoky, more spicy, more what place?
I
would
would
you go?
probably lean towards the spicy side.
A little spicier.
Okay.
Yeah.
Okay.
All right. We're heading in the right direction then.
Yeah,
Okay.
exactly.
Good.
Now, Mike, where did you grow up, and what's the specialty food in that region that you grew up in?
Wow, what a great question. So I grew up in Philadelphia, Pennsylvania.
Okay.
And I was raised on soft pretzels and cheesesteaks.
Actually, not very spicy stuff coming out of Philly.
I'm Italian, so I grew up eating Italian food.
Okay.
My grandmother every Sunday, had incredible Italian meals, but
Yeah.
Philadelphia is just notorious for cheesesteaks and, whiz with or whiz without
Yo,
fried
of course.
onions.
Yeah.
The Pat's, Geno's, kind of when I was growing up a long time ago, but now there are so many great cheesesteak places. But that was the good stuff.
I love it. I love it. Well, our audience is focused on both, medical group growth and technology piece. And as you think about that in your role for SHO, how do the systems that you work with really approach that question? You've definitely got a lot of different organizations, small, medium, and large. Are they tackling things in a similar fashion? Are they tackling things in a different fashion? And how do you support them as they're making choices about technology?
Yeah, it's a technology and AI and, just optimizing the medical record.
Yeah.
So many challenges for the community-based rural hospitals
Yeah.
that don't have the depth, the bank, the wallets, the investment capabilities. So there are lots of challenges. From our seat at the SHO level, we try to provide guidance, from a contracting perspective, from a resource perspective, resource meaning tools, people, tech, setting up situations where the hospitals may have a chance to get something in a group fashion
Yeah.
that they wouldn't necessarily be able to achieve or bring on by themselves because of their scale and size. I mean, we have some hospitals that have 25 providers total, all the way up to hospitals that have 300 providers.
Right. And do you find the physicians have different demands or interest, or is it still pretty consistent with the physicians that you worked with at other organizations as well? I guess from a rural versus urban perspective, or a small hospital versus larger hospital perspective, are there some key differences that you've picked up on, or a lot of the same questions and a lot of the same issues?
Yeah, fantastic question. That's an issue that we deal with all the time. I have unique experience just because of my consulting background and working with large hospitals and systems, some academic medical centers. They just have such different availability to resources. So, our smaller hospitals, they want the tech, they want to be innovative, they want to be on the cutting edge of, having reporting and data and analytics and informatics in general.
Yeah.
They just want to be able to optimize their EMR capabilities.
Right.
And I have noticed that the smaller hospitals really struggle in those areas. Just data accuracy, transparency. It's a huge daily and weekly issue. Where in the big systems, I don't think it really is. That's probably the most glaring piece that I've noticed.
Yeah.
So how's the communication aspect from the SHO kind of corporate level down to the facilities, or maybe not down to, but speaking with and communicating with all those facilities? How does that work? And how do you kind of channel the decisions that are made to the physician level?
An enormous number of meetings. We have affinity groups that have representation from most, if not all, of the hospitals across the network. So let me clarify, 18 of our hospitals are Indiana-based, and SHO has been around for 30 years. Traditionally, we were 13 or 14 hospitals the last 26, 27 years. Just in the last 2 years, we've expanded our membership into Ohio.
Wow.
That represents 11 or 12 independent community-based rural hospitals. So together it's roughly 30, 31. So for the Indiana hospitals, there have been affinity groups and a communication kind of network and protocol that we've been following for decades.
Yeah.
And it actually is pretty effective. In some ways, we function as a pseudo system from a governance and communication and engagement perspective.
Yeah.
It has represented a little bit of a challenge with the Ohio membership and expanding outside of the state, but so
because
far
the regulations are a little bit different, or because of the competition? Or?
regulations, competition, the easy answer is all of the above, just the distance, the different geographies, different payer situations. So it's an ongoing task or challenge.
Yeah. Yeah.
Do you see the physicians in each one of those facilities have kind of some of the topics we've been talking about a little bit today are, transparency, of provider compensation, trust, engagement, some onboarding things. I assume all those facilities that are within the SHO spectrum have similar complications. Can you talk about those complications and what are some of the facilities doing well at communication, building trust, building engagement? What are some of the struggles that are happening? And does SHO have kind of a leadership role in any of that?
A lot to unpack in that question,
Yes.
but a really good one. So all of our hospitals are on different EMRs.
Okay,
So that immediately represents
100%.
a challenge from a governance and pseudo system or system perspective. The hospitals are very dedicated to being independent, remaining independent. So they've invested the right leadership and resources, leadership time into data transparency and reporting and dashboarding and just clinical informatics in general. It's an ongoing battle. As tech changes, as AI evolves, as the EMRs become a little bit more sophisticated, there's a lot of change. But the hospitals are trying to figure this stuff out on a daily basis. As it relates to physician and APP compensation, transparency for us for SHO is I guess transparency, integrity, and accuracy were areas of opportunity just a year or two ago.
Yeah.
We've made some dramatic improvements across the network in those areas, but we still have a ways to go.
What are some of the detailed categories that you're improving in some of that connectivity, transparency, and data sharing?
I would say just regular cadence for productivity reporting.
Okay. RVUs, patient visits, procedure counts, those sorts of things.
Procedure counts, encounters, both for physician and APPs. We get into staffing ratios a ton, and incorporating a lot of the population health and value-based care quality metrics and some of the utilization metrics into those reporting capabilities so that the providers can have more of a holistic picture and snapshot of what they're being judged on ultimately.
Yeah. Well, with that question, it's time to take another step in our journey here. Let's pick up the heat a little bit, Phyllis.
What's this one called?
This one is I think this is the green machine or green something. It's got a little bit of that salsa verde kind of action going on, I feel like. What do you think?
I like it.
Yeah? You feel like spicy than the previous one, or the previous one is spicier? This one's rated higher from a heat signature, but it doesn't taste spicier, in my opinion.
It doesn't taste spicier, but it's definitely got a little more of a punch.
Okay, all right.
But I like it. I really like it.
Dan, you think this is spicier or the last one?
No, I
spicier?
don't. It doesn't feel. And maybe it hit me here in a minute, but right now it feels like that would be my choice of.
This one I would order.
Yeah,
It's good, right? It's got a nice
Oh, yeah.
balance. Yeah, it's got a little bit of different flavor. Yeah. Unless you're going with more of a traditional barbecue, maybe the first one's got a little bit more smoke, like you said, from a brisket perspective. You know. But this one you could put. I mean, probably couldn't put it on a cheesesteak. Probably not so much.
Not in Philly, you couldn't.
No, not at all.
No.
You could
In
maybe do
Nashville,
some
you could.
chips.
Exactly. Yeah, exactly. So, Mike, one of the things that we love to talk about here on System Logic is sort of the back office, the administrative roles and technology, filling some of those roles. How do you view both the evolution of medical group leadership and the integration of technology into that leadership from where you sit at SHO?
It's a huge opportunity.
Yeah.
Our hospitals are community-based rural hospitals.
Yeah.
And, mentioning the budgets and resource capabilities compared to the larger systems.
Yeah.
It represents an opportunity for these smaller places where technology can improve efficiency and help with, patient volumes and increased or improved production.
Yeah.
So we view that at Suburban as a huge opportunity for all of our hospitals and all of our providers, both physician and APP.
And are those facilities resistant to that at all, or they're open to it? It's just the resource constraints that you were mentioning earlier are a barrier.
Another great question. So some are very open, some are resistant. In some of these communities, you have, believe it or not, legacy or older physicians that are towards the end of their careers where they just don't want to adopt technology and
Yeah.
and look at something on an app or an iPad or spend more time in front of a screen.
Yeah.
So that's always a challenge. And a lot of these communities struggle with recruiting and retention.
Yeah.
So they're not going to do anything to disrupt the practice of a older established physician.
That's a good point. That's a good point. Whereas a place that is in downtown Philly, for example, or in Indianapolis, they might have less qualms about making some of these changes because recruitment is more of a cyclical. Well, there's a bigger flow of in and outs that they could recruit more into.
Absolutely. Geography and location, huge variables in the equation.
Yeah, hadn't thought about that too much.
So in your history as a consultant, you spent a lot of time in the value-based world. And from what I know about you, that's a high passion of yours, which is wonderful. I think there's a lot of lack of understanding in the value-based world as to what metrics are working, which ones are not, how to measure that, how to provide communication, transparency in the value-based world. Can you talk about your experience a little bit, and where did that passion come from, and how do you see yourself using that today in your role?
So when I started my consulting career 17, 18 years ago, I was at PwC, and I was involved very early on in some of the pioneer ACO models and strategy that CMS put out, and just immediately developed a passion and interest for that space. As my career in consulting progressed, I spent a ton of time trying to optimize and build efficiency and strengthen primary care service lines. Yeah. And I think that's where the connection naturally developed with population health and value-based care. So much of it is centralized around the primary care provider. And then as the APP workforce started to evolve and grow, APP comp and APP pop health performance started to become as important as physician performance in the value-based care space. But being able to provide the providers in our network with some guidance around value-based care, accountable care organizations, Medicare Advantage risk situations, commercial risk situations, and then marry that with the compensation piece has really been a huge benefit to the hospitals at Suburban.
I think that transition and some of the differences with the APPs and the physicians, and I think about some of the technology tools that I come across in California where I live, and some of the tools that are just fantastically amazing when you put them into use. And I wonder how much adoption there is in some of these rural and smaller hospitals, and whether or not you think that is a hindrance, a help. You talk about some physicians that are resistant to some of the technologies, but something like an ambient scribe or something that could help with coding and make things a lot smoother and faster. Not only would that assist both sides of the equation, the APP side and the physician side, but also the entire clinical enterprise and the access question are enhanced by some of these agentic AI tools out there. How have you seen that adoption in your organization and some of the hospitals that you work with, or is it still pretty arm's length at this point?
The adoption of those tools has increased tenfold in the last couple of years.
Okay.
As value-based care.
Even in some of these smaller facilities that are generally resistant to some technologies.
So as value-based care grows in importance and people start to realize that it's not going to go away and we have to fix Medicare as much as we possibly can. Also, those thoughts combined with the fact that at the SHO level, we help orchestrate a lot of the population health and value-based care contractual pieces.
Okay.
It gives the individual hospitals, the independent individual hospitals, more motive to adopt, new resources from a tech perspective. Ambient scribe, all of these different pieces, so that they can become more efficient. They can earn shared savings. They can see more patients. They can deliver better care. So it's in our network. It's been a little bit slow compared to the bigger players, but it's here.
Okay. Okay. Well, it's time to deliver a little bit more spice now, gentlemen, and we're going to go to the last level 6 here. See what you think.
Much more mustardy.
Mike, what do you think? You like this one too?
I do like this one.
Okay. All right. So 4 not so much, but 5 and 6, Mike likes those
I
two.
see, I see that.
I'm definitely sensing some
Might have
mustard.
to take a bottle home here.
Yeah, exactly.
No.
I like it. I like it. Well, like I said, as the heat rises here a little bit with the spiciness, have you ever had to work with hospitals that certainly you guys have large meetings, a lot of hospital CEOs or medical group CEOs that are around the table. What are some of the spicy questions or spicy takes that you've gotten over the years in your role? Anything that you can share with the audience?
I don't know if we have enough time.
Yeah.
I often get asked how we can use population health and value-based care and even physician compensation to help recruit and retain providers in all specialties. That's kind of my area, my niche. So I get those questions, especially as they relate to recruitment and retention. Most of the conversations in the last 18 months have been around advocacy and what's happening at the state government level and
Reimbursement standpoint.
reimbursement.
Yeah, sure.
Medicare, Medicaid, cuts, changes. So that's where a lot of the discussion is channeled today.
I can imagine.
Yeah, so let me lean in a little bit on the recruitment aspect when it comes to how are you educating or providing education to the recruitment teams if there is a recruitment team. Sometimes smaller organizations don't have the ability to have a recruiter in-house. But how do you provide that communication in the recruiting experience around value-based metrics and population health?
Yeah, so we try to convey to recruits and potential candidates that many of our hospitals across the SHO network have flexible models in all specialties where a physician or an APP can have a chance to be a high earner. It's not like it was 5 and 10 years ago where comp models were standardized and almost off the shelf templated situations where this is what MGMA says, this is what it's going to be, this is your salary.
Right.
In fact, it was just a couple of years ago we had some physicians at some locations on salary models.
Right.
Just very unique situations. Again, depending on demographics, geography, location, access. Access is such a huge piece.
Absolutely.
But as we have discussions with new providers for our network, for the SHO hospitals, talking to them about newer comp models and how it's more flexible is something that I think is really intriguing to them.
I'm curious, do you ever come across providers where they actually are viewing the smaller and rural facilities as an opportunity to kind of get out of the rat race a little bit? Or are they seeing that as a chance to kind of cool off some of that burnout that they're feeling at downtown Indianapolis or downtown Chicago hospital, something like that?
Absolutely. I think some of our hospitals serve as a refuge, to be honest with you.
Yeah.
The getting away from higher, what's the right word? I guess higher
acuity for sure, and certainly higher pressure
Definitely.
Groups, I think, yeah.
And the fact that in those metropolitan urban areas, there's just a higher pool of candidates.
Yeah.
So if you're a good provider with good quality and you see the right number of patients in a rural setting, you can have a really nice career and be a part of the fabric of the community.
Right.
So to answer your question directly, we do see physicians and APPs selecting the smaller community-based setting for lots of reasons.
Yeah. Well, Dan's gonna ask one more question. We're gonna select one more last dab here as we get toward the end of our discussion. But Dan, you have some other thoughts?
Yeah, I was going to kind of talk about the recruitment versus the retention aspect of things. Do you find it more challenging to recruit the physician or retain them? Which is more of a challenge to you? It sounds like some of these folks are coming in to have kind of a different lifestyle, maybe. They can they can make a good living, they can have decent productivity, things like that. So is retention more of the challenge, or is recruitment more of the challenge for you or for your hospitals? Yeah.
I'm thinking through the hospitals that I'm working with today over the last couple of years, and the answers are probably 50-50.
Sure. Yeah.
From my perspective, it's recruitment because it usually involves a relocation or a longer drive, a change to their normal setup. We have kind of solved the retention situation
That's wonderful.
across the network with some of these flexible models. And, you know, if you want to work, if you want to be a 0.75 FTE, you can do that in certain hospitals.
That's great.
That's wonderful.
That's not always the case in larger
That's
downtown systems.
Yeah.
Right.
Yeah. All right. Well, let's try the last one, and then we'll dive into the last couple of questions here. Really get a good dab
Let's
there.
get it
Look,
good.
Oh, wow. You really went for that one. Wow.
He's had such a good experience so far. He's going right,
Yeah.
diving all the way in.
Yeah.
This one tends to linger quite a bit longer.
A little more peppery. I'm gonna go for the milk this time.
Whoa,
Yeah, it's an
that's
upgrade.
That's present.
Yes, that is present.
Yes, it'll be omnipresent for.
Yeah, exactly. Well, Mike, as we mentioned, a lot of new members here at the conference, including this is your second year at the conference. What's one thing that you think you'd like to take away from the discussion? What's one thing you came to learn about at the conference?
I'm here to find technology solutions.
Yeah.
Our hospitals are looking for them. They need them.
Yeah.
And this is a great place. You know, the ones that support physician comp and performance. It's at the SHO level, it's about performance improvement and not just improving production,
Yeah.
right? There's a larger initiative, a larger target.
Yeah.
And then the networking here is amazing.
Absolutely.
Yes, absolutely. And in that vein, as a newer person, you know, a lot of folks in the audience that are new to medical groups or new or even in grad school. What's one word of advice that you would give or offer to some of those new folks that are up and coming and really want to build a career in medical group leadership and health system leadership?
I think there's a great opportunity at this event specifically to absorb the sessions. Sessions are great.
Yeah.
Great topics, great content. Also the vendors and the networking. Stop at the booths, ask about their products, learn from them, hear what the different solutions are, what the pros and cons are of the different solutions. Those are opportunities where I've always felt like I've been able to learn what's working, what's not working. Then I can kind of compare things based on my environment at SHO. So, you know, I think the vendors, the different products, services, you know, whether it's tech or advisory, all of the above, they all have different value to add.
Yeah, just one additional thought to that is I would encourage the folks that are new to this to, in their networking, to meet other folks. But when you run into a situation that's challenging for you, to not spend too much time trying to reinvent the wheel, but spend more time reaching out to the people that you just networked here at the conference, right? Reach out to them and say, what have you done in this situation? So you're not spending too much time trying to figure out, you know, because you start thinking, man, I'm the only one experiencing this. But you come here and actually there's 200 colleagues, right, or more, that have had the same experience.
Reminds me of a situation last year where I had a couple of conversations around pediatric compensation.
Yeah.
And the people that I met at this conference last year gave me great insight.
Yeah.
And
We dealt
you're-
with that last year. Here's 5 things you can do.
Yeah,
Right,
and
right.
I mean, just the networking capabilities, to your point, Dan, are incredible.
Now, Mike, you, unique amongst a lot of our guests, have had a chance to travel the world and been to a lot of places. Where is the spiciest food that you have had in all the different places? I know you've lived and worked in a lot of different countries and whatnot. So tell us about either the best or the spiciest food that you can recall.
I was living with my wife and kids in Sicily,
Okay.
and I had a bowl of pasta.
Yeah.
And it was called penne arrabbiata.
Oh.
And the chef was a friend of ours.
Okay.
And we were warned, but this bowl of penne pasta with some hot sauce, hot
Yeah.
tomato sauce,
Yeah, yeah.
was like nothing I had ever experienced.
Interesting. It looked normal, like a normal tomato sauce, huh?
Yes.
But it was just
It quickly turned into a bowl of pasta arrabbiata with a lot of cheese
Oh, yeah, yes.
to calm things
To
down a
calm
little
things
bit.
down a
But
little
it was
bit.
delicious, but
Yeah.
it was a heat that I don't forget.
yes.
Okay.
Yes. Absolutely. Absolutely.
Maybe we have a new name for our next year's comp challenge,
I think
right?
so. I think so. Yeah. Well, listen, Mike, thank you so much for carving out a few minutes, joining us today on System Logic Podcast and taking the Hot Comp Challenge.
Thanks for having me. Appreciate it.
Yeah. Well, that's our show at the System Logic Podcast Hot Comp Challenge with Mr. Mike Gizzi, co-host Dan Iliff. If you'd like to hear more conversations like this, please like and subscribe. Join us on YouTube, Spotify, or Apple. And we'll see you next time on System Logic.